For drugs with a long half-life, if it is unacceptable to wait for 5 half-lives until concentrations within the therapeutic range are achieved, then an initial loading dose can be given that is much larger than the maintenance dose and equivalent to the amount of drug required in the body at a steady state. This achieves a peak plasma concentration close to the plateau concentration, which can then be maintained by successive maintenance doses. A steady state actually involves fluctuations in drug concentrations with peaks just after administration followed by troughs just prior to the next administration. The manufacturers of medicines recommend dosing regimens that predict that for most patients, these oscillations result in troughs within the therapeutic range and peaks that are not high enough to cause adverse effects. The optimal dose interval is a compromise between convenience for the patient and a constant level of drug exposure. More frequent administration, example 25 mg 4 times daily, achieves a smoother plasma concentration profile than 100 mg once daily, but is much more difficult for patients to sustain. A solution to this need for compromise in dosing frequency for drugs with half-lives of less than 24 hours is the use of modified release formulations. These allow drugs to be absorbed more slowly from the gastrointestinal tract and reduce the oscillation in plasma drug concentration profile, which is especially important for drugs with a low therapeutic index, example levodopa. Inter-individual variation in drug responses. Prescribers have numerous sources of guidance about how to use drugs appropriately, example dose, route, frequency, duration for many conditions. However, this advice is based on average dose response data derived from observations in many individuals. When applying this information to an individual patient, prescribers must take account of inter-individual variability in response. Some of this variability is predictable, and good prescribers are able to anticipate it and adjust their prescriptions accordingly to maximize the chances of benefit and minimize harm. Inter-individual variation in responses also mandates that effects of treatment should be monitored. Some inter-individual variation in drug response is accounted for by differences in pharmacodynamics. For example, the beneficial natriuresis produced by the loop diuretic furosemide is often significantly reduced at a given dose in patients with renal impairment, while delirium caused by opioid analgesics is more likely in the elderly. However, it is differences in pharmacokinetics that more commonly account for different drug responses. Examples of factors influencing the absorption, metabolism, and excretion of drugs are shown in box 2.4. It is hoped that a significant proportion of the inter-individual variation in drug responses can be explained by studying genetic differences in single genes, pharmacogenetics box 2.5, or the effects of multiple gene variants, pharmacogenomics. The aim is to identify those patients most likely to benefit from specific treatments and those most susceptible to adverse effects. In this way, it may be possible to select drugs and dose regimens for individual patients to maximize the benefit to hazard ratio. Personalized medicine. Adverse outcomes of drug therapy. The decision to prescribe a drug always involves a judgment of the balance between therapeutic benefits and risks of an adverse outcome. Both prescribers and patients tend to be more focused on the former, but a truly informed decision requires consideration of both. Adverse drug reactions. Some important definitions for the adverse effects of drugs are: adverse event, a harmful event that occurs while a patient is taking a drug, irrespective of whether the drug is suspected of being the cause. Adverse drug reaction, ADR, an unwanted or harmful reaction that is experienced following the administration of a drug or combination of drugs under normal conditions of use and is suspected to be related to the drug. An ADR will usually require the drug to be discontinued or the dose reduced. Side effect: any effect caused by a drug other than the intended therapeutic effect, whether beneficial, neutral, or harmful. The term side effect is often used interchangeably with ADR, although the former usually implies an ADR that occurs during exposure to normal therapeutic drug concentrations. Example: vasodilator induced ankle edema. Hypersensitivity reaction: an ADR that occurs as a result of an immunological reaction and often after exposure to subtherapeutic drug concentrations. These include acute anaphylaxis, the result of an interaction between drug antigen and immunoglobulin E (IgE) on mast cells and basophils, resulting in a release of vasoactive biomolecules. Example: penicillin, saxamethonium. This is also known as type 1 hypersensitivity reaction, anaphylactoid. Box 2.4: patient specific factors that influence pharmacokinetics. As drug metabolism is low in the fetus and newborn, may be enhanced in young children and becomes less effective with age. Drug expression falls with the age related decline in renal function. Sex: women have a greater proportion of body fat than men, increasing the volume of distribution and half life of lipid soluble drugs. Body weight: obesity increases volume of distribution and half life of lipid soluble drugs. Patients with higher lean body mass have larger body compartments into which drugs are distributed and may require higher doses. Liver function: metabolism of most drugs depends on several cytochrome P450 enzymes that are impaired in patients with advanced liver disease. Hypoalbuminemia influences the distribution of drugs that are highly protein bound. Kidney function: renal disease and the decline in renal function with aging may lead to drug accumulation. Gastrointestinal function: a small intestinal absorption of oral drugs may be delayed by reduced gastric motility. Absorptive capacity of the intestinal mucosa may be reduced in disease, example Crohn's or celiac disease, or after surgical resection. Food: food in the stomach delays gastric emptying and reduces the rate but not usually the extent of drug absorption. Some food constituents bind to certain drugs and prevent their absorption. Smoking: turn in tobacco make tobacco smoke stimulates the oxidation of certain drugs. Alcohol: regular alcohol consumption stimulates liver enzyme synthesis, while binge drinking may temporarily inhibit drug metabolism. Drugs: drug drug interactions cause marked variation in pharmacokinetics. Page 19.